Hi, pediatric dermatology in 7 minutes. Can we do it? Let's give it a try. When a child walks in with eczema, we now realize that there are other things we need to worry about. This was a big study just published in the last few weeks looking at comorbidities in kids with eczema. Almost 90,000 kids were evaluated with matched controls via retrospective review of their charts. And it was found that odds ratios for particularly alopecia areata was increased, and more worrisome, the risk of a hematologic malignancy also was increased. So we need to keep this in mind when we see pediatric patients with eczema. What about treating these kids? Wonderful study that helps us put an old fear to bed. Amy Peller and her colleagues reported on the registry that had been in existence for more than 10 years, where children with atopic derm onto tacrolimus were followed. 2,000 made it to the end of the study. The release of the black box warning scared a lot of families and they discontinued using the drug. But at least we had those 2,000 and it was found no increased malignancies and no lymphoma. Great news for our patients and for us in terms of using this drug with less fear. What else is out there? Crisaborole, the boron-based phosphodiesterase inhibitor, has been studied extensively now in children, and there is no accumulation of propylene glycol that has been shown. And this study and others helped to lead to FDA approval in children as young as 3 months of age. Very exciting. And this gives us that information when the insurance companies say, oh, it's not FDA approved. Wrong-a-roo. This is FDA approved, and I want it for my kids. What about severe atopic dermatitis? What do we have? Well, dupilumab has been around and has been shown to be wonderful in adults, and we now have data in kids. This study in the BJD and others showed that dupilumab is both safe and efficacious in young children, very similar to adults in that conjunctivitis is probably the most significant finding. So those studies helped lead to FDA approval of this drug for kids 6 to 11 years of age. It is coming for younger children, but dosing has been a challenge, I think, particularly in the younger children. And I wanted you to be aware that in very small people, in this, you can see that those 15 to less than 30 kilograms need a loading dose as much as the adults do, but they only need to be retreated every 4 weeks with 300 milligrams, whereas those in the middle ground, 30 to 60 kilos, need a loading dose of 400, retreated every 2 weeks. So look at these graphs before you start treating your patients, but it is a wonderful drug, which is major quality of life difference. Kids and COVID, do they get it? Yes. Is it a big concern because of school openings, et cetera? Yes. This is from the CDC COVID response team, which this was shared at a recent meeting I was at, and they have collected, as of February, almost 3 million childhood cases have been documented. 12.9% of all COVID cases seen. Good news here, hospitalizations are low, mortality is low. Bad news is Hispanics and Blacks appear to be overrepresented, as is seen from the seroprevalence residual serum study done from the University of Mississippi. And again, much of this data is not in published form yet, it's online, but there is a nice review of COVID in children in the JAMA Pediatrics article I've referenced. What about COVID then? Is there nothing to worry about? Well, we can't relax yet. Here we have Andrew Cuomo and better times for him in May of last year, identifying and sharing with us that there was a severe illness noticed in New York that seemed to be associated with COVID disease in children. And in fact, this was reported in multiple states. Here's a New England Journal article published which showed that this disease, the moniker they chose for it was multisystem inflammatory syndrome in the US in children and adolescents. So you'll see it as MIS/C. This has been reported in multiple states. These kids look like Kawasaki's, but they're a little bit older. They have a predominance of GI symptoms. Often severe cardiac findings can be seen too. The lungs can be involved, but not as big an issue as it appears to be in adults. The difference with this disease and Kawasaki's is the kids are a bit older, as I mentioned, and they have low rather than high platelets. And most of these kids will survive, but it is a severe illness, which we want to recognize. Interesting thing, it's been found when we look at graphs of acute infections or hospitalizations with COVID and superimpose that on the graph of when we see MISC, and you can see that it is not probably an acute infectious phenomenon, but rather a post-infectious phenomenon. You can see that it's multiple weeks after the acute surge of disease that we see the surge of this disorder in children. So a peri-infectious and inflammatory mediated, fascinating. Our job is to recognize it and get the right help for these kids. So if I were to show you these beautiful pictures of these scalps, one in a baby, one in young monks from Myanmar, you would see that they have got on dermoscopy, if you bother to do it, corkscrew hairs, and they've got tinea. And good news, there is an encapsulated formulation of terbinafine that appears in this very preliminary pilot study to be useful in treating these kids. In this study, 100% of the 10 children treated had mycologic cure. Molecular classification of red birthmarks. This is a major issue in young children. Fortunately, not that common, but kids who come in with vascular birthmarks and overgrowth. And what we know now is that this is not genetic at the time of conception. It's a postzygotic mosaic oncogene mutation. And they're activating mutations, as you can see, PIK3CA, GNAC. The degree of severity in these kids depends on when the activation and the mutation occurs and what part of the body. We can now take a sample of these tissues and run them against a chip for different vascular mutations and identify which mutation has occurred, which is important in terms of treating them. This was a study in Nature that showed we can now use cancer medicines to treat these kids. And now, last but not least, some fun with newer presentations of an older disease. This is a 10-year-old who came in with a blistering rash, and he didn't really have any pain. It was on his hands, neck, and feet. He had autism spectrum disorder and odd grazing habits. He wouldn't eat regular food. He loved popcorn and apples. And if we had the sense, as the authors of this study did, to get nicotinic acid and nicotinamide levels, they are very low. He has pellagra. So what is that? The cellular deficiency of niacin or vitamin B3. And it's interesting that the Indians knew to treat maize and corn with alkali like lime or ash to release the B3 and therefore to protect people from this disorder. It can be seen in malabsorption as well. And in this beautiful case report, they mentioned that ASD children, autism kids, have weird diets and they're at higher risk for these nutritional deficiencies. Scurvy has been reported in kids with autism spectrum disease. And recently, an abstract at an SPD meeting showed a toddler present with zinc deficiency type rashes in a case where he had been treated. He had a seizure disorder and was treated with a ketogenic diet. So we are done. What have we managed to do? Well, hopefully I've convinced you that crisaborole and dupilumab are to the rescue for us. COVID in kids is okay, but keep your eyes open for MISC. Cancer drugs can now be used for vascular malformations, and funny diets lead to funny rashes. And thank you so much.